a very important topic. It has concerned many people, and that is the hypertension and COVID-19. More specifically, does hypertension increase the intensity or severity of the COVID-19? So let us start. The basic first question, are the people who are hypertensive at a greater risk of catching the disease? The answer is no. The people, hi Yasmin, how are you? Welcome. So people who are hypertensive do not have a higher risk of getting the infection. It is the same for everyone. It depends upon the prevention. It depends upon our hygiene. It depends upon our exposure. It depends upon our protections. So that itself has no bearing on hypertension and COVID-19. Now, the second question that is really important is that people who are hypertensive, if they get COVID-19 disease, are they at a greater risk of severe outcome? So the answer to that, and I would explain it in detail later on today, the answer to that is also no. So of course, you're going to now say that, Mubin, you're wrong, because all of the studies show that one of the higher comorbidities are hypertension. For example, the Chinese data says that the cardiovascular issues as a comorbidity was 10% of the contributor to the death. And then the hypertension itself was 6%. So people who are dying in China up to February 11, in the people who died, 6% had hypertension as a comorbidity. Compare that to 0.9% of the people dying who had no comorbidity, so 6 times higher or more. So you can definitely come back and say, why is Mubin saying that hypertension itself has nothing to do with the severity of the disease? And so I would explain that once again, that it is not the hypertension itself, but it is the people who have hypertension may be of a greater or higher age, advancer age, or people who have hypertension may have drugs that they are taking that may affect their outcome, or people who have hypertension may have other comorbidities, for example, cardiovascular system issues that may make them more prone to severe outcome with COVID-19. So it is not the hypertension itself. It is the reason, walaikum assalam to everyone, it is the reason that somebody has hypertension, and age is one reason. Most of the folks who are older have hypertension, but that simply means that they would have other comorbidities. They may have cardiovascular issues, they may have diabetes, they may have other immune issues, and that might be the contributing factor. So first, we have to agree on this one baseline, that hypertension itself has nothing to do with the COVID-19 severity. Good? Are we all on the same page? And I'm going to explain it. I have a bunch of studies here and I have a bunch of mechanisms, but as long as the basic topic is concerned, we are done with the discussion. So if you wanted to skip this discussion and go and do something else, sure, you can do it. My only request to you will be, please share these videos. Please share this. Okay, so now let's start discussing. So I'm going to share my screen. So here is a study that is interesting for us to look at. That study is from, let's see, let me bring that here. Are you able to see this? Okay, so if you're seeing this, here is the study. This study is not yet, I believe it is not yet peer reviewed, or this study has some limitations that are really important. So let's look at the limitations before we look at the study. So one important limitation that they are presenting is this. Here, look at this. However, this case series design cannot address the complexity of this question. The question is, should the patient continue to use ARBs or ACE inhibitors or not? And the results are, look at this, the results are unadjusted for known confounders. So what they have done is, I'm going to show you some data about the patients who had been using ACE inhibitors and angiotensin receptor blockers, or ARBs. And what they are saying is, the authors of the study are saying, we have not adjusted this data according to the age brackets or according to the ethnicity or according to the other comorbidities. And look, guys, other comorbidities, for example, diabetes or cancer or immunosuppression or heart diseases, can actually contribute to the mortality in COVID-19. So it doesn't mean that somebody who is on ARB or ACE-I may have a problem. So that is what is important to see here, that this data that I'm going to show you is not adjusted with those extra layers of data. And so that is a severe limitation when we look at this data from hypertension's point of view. So let's look at this data though. Now that we have that, that warning. So the data is, hello back to Siddhartha from New York. So the data is this is the study presenting characteristics, comorbidities and outcomes among 5,700 patients hospitalized with COVID-19 in the New York area. What I would like us to look at is this data. So let me first go back to my, excuse me, my pen just fell. Okay, so first of all, let's look at it. I'm talking about the same study in New York, 5,700 patients. What they saw was 56.6% patients had hypertension as a comorbidity. We're not talking about the mortality. We're talking about the patients who were confirmed with COVID-19. Out of those patients, 56.6% had hypertension. Once again, it is not the problem with the hypertension. It is the age and other comorbidities which make a person more vulnerable and to end up in the hospitals. Hypertension does not have much to do with COVID-19's disease severity. Obesity was a second, 41.7%. And I think I should also say this, that hypertension so far is not known to do anything. Maybe there are some future studies that would come in and they'll say hypertension itself has something. I doubt it, but till now, there is nothing. Obesity was a second bigger comorbidity for the people coming in with COVID-19 in the hospitals. These are hospitalized patients. So that means they definitely had some symptoms that were more severe than the mild form, and they needed to be in the hospitals. So hypertension 1, obesity 2nd, and then diabetes 3. These were the comorbidities. Then, so Siddhartha, I'll look at that question in a second. The second thing that was interesting is this, and we are going to look at that data, and I want you to please keep in mind the author's disclaimer that this data is not adjusted to the ethnicity, to the race, to the age group, to comorbidity. So there is a problem with the data that we cannot just look at it without digging deeper. So here is what they're saying. Mortality rate, people who had hypertension, so now we are talking about the people who died, who had hypertension but were not on ACE inhibitors or ARBs, their mortality rate was 26%. People who had hypertension plus were on ACE inhibitors, their mortality rate was 32%. And people who had hypertension plus they were on angiotensin receptor blockers, ARBs, their mortality rate was 30% after they became hospitalized. Now, once again, what is not known in these parts is, did they have diabetes as well? Did they have cardiac disease as well? Of course, somebody who has hypertension and is old, I would suspect that they may have other cardiac issues too. So it is not necessary that this higher number is because of ACE inhibitors or ARBs. This number could be for other confounding factors. But I wanted to show what we have in the study. The interesting thing that really was, I was smiling when I read this, although the end result was still not good, but patients who had hypertension, they were less likely to receive invasive mechanical ventilation. The sad part is that we're talking about the patients who died. So eventually they died maybe because of some other comorbidity. So that is a sad part. Every single death is too much. So when I sometimes see, I have sometimes on the Facebook, people putting in the count is lesser than flu and stuff like that. Look, every single death is too much. I was thinking yesterday, so for 3-4 days, I have dry cough. And yesterday I was short on breath as well. So I thought maybe I got COVID-19. And I was thinking that if my family loses me, I may be a count in the bigger picture, but for them, I am a family member. I have a value and importance. I have love. And so that itself cannot be measured with numbers. So please realize that people who are dying, every single person dead is too much. So the people who died, out of them, all of them, if they were hypertensive, they were actually less likely to receive invasive mechanical ventilation. Why? We don't know. From other studies, I have a couple of theories that I would like to share with you in a few seconds. Second point that study makes, and this is very important, patients who were on invasive mechanical ventilation, those patients who had gone on ventilation, and then from them, patients who had hypertension, but they were not receiving ACE or ARB, 42.5% died. Patients who were hypertensive were on ventilator plus were on ACE-I, 58.2%, and then same profile but using ARB, 56%. Once again, their number is higher, but the authors have not responded to this question that is their number higher because they are taking these drugs, or is their number higher because they have other comorbidities or they have other complications, and maybe that is why they were also using ACE-I and ARBs. Then down here, these are the patients who were in the ICU. So remember, if they are on the ventilator, so they are in a critical state. If they are on ICU, they are still serious, but not as critical. And in the ICU patients, the ones who were hypertensive and were not on ACE or ARB, 43% died. Hypertension plus ACE, 60% died. Hypertension plus ARB, 60% died. So once again, the question mark stays for all of them, that were there other reasons that the patient died. So I would suggest that the study itself is not complete, or study for ARB and ACE inhibitors is not sufficient. Instead, and the study does not claim to be that, the study says that we are only looking at comorbidities and outcomes among 5,700 patients hospitalized with COVID-19 in the New York area. So they're not claiming that we are talking about ACE inhibitors or ARBs. They're simply saying that, hey, this is what we have found. So now let's go to this very important and interesting table. This is part of the study as well. And what they're doing in here is, there are two tables. One is the clinical measures and outcomes. And then the other one is clinical measures and outcome of the patient discharged alive or dead at study endpoint by home medication. This one was by comorbidity. So let's look at it for a second. First, let's become a little more comfortable with this table. Because this is an unadjusted table, we got to kind of see it in a different way. First of all, for each category, they have given the number of patients here. And this percentage is out of this number. So this percentage is not to compare with the other, or it is not a percentage from other numbers or collective number. This is a percentage here out of this. So how do we read this? Let's say patients who are on invasive mechanical ventilation. I'm going to go here, and out of these patients, the patient who died and were diabetic, their number was 224. So you have to sum up all the remaining numbers to see what percent of the people actually died. And you would see that that number itself was not very large. Look at this. Non-diabetics discharged 1548, discharged diabetic 533, died non-diabetic 329, died diabetic 224, discharge, and so on. So the first important thing is that this percentage here is out of this number and not the collective number. Number one. Number two, look at this. Died with hypertension 384, died non-hypertension 169. What that tells me is that normally hypertension is not in the younger ages, unless there are comorbidities or obesity or other issues like pheochromocytoma or adrenal problems. Normally, hypertension is a disease that starts in the later ages. So people who are in the later ages, we already know that they are at a higher risk of severe disease. So it is not hypertension. Hypertension is just an indicator that this is the group that is in advanced age. So if I go down here, this is another one, same way to read, but this is by the medication. And in this medication, they are looking at ARB and ACE, and that is really important. So look at this. Discharged hypertension, no ACE or ARB. Discharged hypertension with ACE, discharged hypertension with ARB. So look at the numbers, 699, 113, 170. I did a complete percentage count before. So out of all of them, out of all the patients who were either discharged or died, the total number, 70% of the patients were discharged. So please realize that if you are hypertensive and you're using ACE or you're using ARB, and if you become enough serious to end up on ventilators and in ICUs, even then 70% of the patients will be discharged. So it is not that if you are hypertensive, there is a problem. As I said before, hypertension doesn't have any relationship with COVID-19. Secondly, if you're on ACE-I or ARB, that is also not a thing to say that this is definitely a bad thing. I'm going to show you why this may or may not be a problem. Both sides I want to show. So here, if you see, I've taken this table, and that is what I had summarized here. Now let's continue. So far, the takeaway is that hypertension, no direct relationship. This is a summary of so far the discussion. Secondly, people who are taking ACE-I and ARB may actually be protected, although the data shows that they are not. However, authors admit that they do not have all the factors or confounding factors taken into account. So now if we try to make an understanding of what ACE-I and ARBs may be doing in hypertensive patients, and is that useful or not? So let's look at some of those studies and data and mechanisms. So I'm going to continue. So here is the important couple of things here in the mechanisms. Number one, hypertensives are usually older people, have more prevalence of hypertension. What that means is if you meet 70 years old, maybe out of 100, there may be 50% of the people who are hypertensive or more. And if you meet, let's say 30 years old, 100 of them, there may not actually, there be 0% hypertension possibly. So first, the older age itself. And that means, again, age itself is also not the problem. Older age has other comorbidities that make people serious, like diabetes and heart diseases. I would look at that more importantly than hypertension. Yes, this is true that hypertension itself causes heart issues as well, but it won't cause that in 2 days. If the patient has heart issues, they have heart issues. If they do not have heart issues, they do not have heart issues. Hypertension, if I get hypertensive today and then I get COVID-19 as well, I will not get my heart failure tomorrow unless I have other issues that make me very weak and vulnerable. So with this, patients who are on hypertension, who are hypertensive, on hypertension, who are hypertensive and are on ARB or ACE-I, they are actually supposed to be better protected. And I'll show you both studies saying they are protected and studies saying they may be at risk. I'm going to show you both, but I lean more towards they are better protected. So look at it. Number one, ARB, ACE inhibitors, they block renin-angiotensin system. And I made a mistake yesterday when I was talking about renin-angiotensin system, and I said when the blood pressure is more, that is when renin is released. It was the other way around. So I sometimes make these mind lapses when I'm teaching. My apologies. So number one, ARBs and ACE-Is, they block renin-angiotensin system and they protect us from angiotensin II injury. And I would show this study in a few minutes that can angiotensin II actually participate in lung injury. So why not actually look at that study now? Here is I believe this is the study. This study was done on SARS-CoV, not SARS-CoV-2. So we are talking about a virus that was in 2002 and 2005, and we are thinking that their behavior is very similar. And SARS-CoV as well, it does the same thing. It has a spike protein. It's a coronavirus too. It has a spike protein. It uses that protein to bind with ACE2. We have talked about it in the past. That causes the ACE2 to pull the virus inside the cells. And the study says that because coronavirus in the lungs causes the ACE2 receptors to be down modulated. What does that mean? What that means is if these are lung cells, let's say these are lung cells, epithelial cells, and they have a bunch of ACE2 on them. When coronavirus comes and attaches to these ACE2, of course, the ACE2 are now going to become internalized to take the coronavirus inside. That is how this thing functions. The result will be that there will be less ACE2 on the surface of the cells. Correct? So that is a down modulated, not down regulated. Down regulation means cell decided that I do not want to have more receptors. Down modulated means that the cell's receptors were taken in, for example, by some other factor, here the virus. So as the surface ACE2 are less, now because the virus has used them as a boat to go into the cell, the fewer number of ACE2 receptors are actually dangerous for the patient because that allows the angiotensin II, which is the opposing side, I'll explain in a second, to become freely rampant and do damage. So that is a study here. What they saw was that when the virus comes into the tissue down here, that causes so I'm just kind of scrolling over the important highlights. So when you look at it, you can see it as well. What they're saying is, to confirm whether spike Fc promoter lung disease, leave that part, look at this part. Angiotensin II production, it causes lung disease pathogenesis through increased angiotensin II production and functional alteration of renin-angiotensin II system. We block the angiotensin II receptors with a specific inhibitor. So imagine that may be ARBs. And then the outcome was better. It attenuated acute severe lung injury. So people who are on ARB actually may have a benefit that their severe lung injury may be lessened. Question is why? So let me explain that part. Look, what happens is, let's say this is a cell, lung cell, another lung cell, another lung cell. So let's say they are part of our tracheal tree, and this is our airway, These cells are just sitting at the airway. These cells, and then we have blood vessels as well, and blood vessels are also expressing. So let's say this is a blood vessel in the lung, and the blood vessel is also expressing ACE2 enzyme and ACE1 enzyme. Remember, we discussed this yesterday, that ACE enzymes are present abundantly in the blood vessels of the lung. We also know that ACE2 are present abundantly on the epithelium and the other tissue cells of the lungs. Now what happens is, so please, here is the whole mechanism. What happens is, ACE2, we know that liver makes angiotensinogen, which renin from the kidney causes and converts that, works on it and converts it to angiotensin 1. Then when this angiotensin 1 passes through the lungs in the blood, the ACE angiotensin converting enzyme, ACE enzyme in the blood vessels, converts angiotensin 1 to angiotensin 2. Angiotensin 2, in our context, what is important is, once it causes vasoconstriction, so it causes hypertension. If it actually regulates blood pressure, it doesn't cause hypertension. But in hypertensive people, this is one of the reasons for hypertension. Number one. Number two, it is pro-inflammatory. This is what is important. It is pro-inflammatory. That means it promotes inflammation in the tissue where it is present. They are speculating in that study, and then they proved it, that with SARS-CoV, not SARS-CoV-2, with SARS-CoV, angiotensin, when present without ACE2 as a monitoring or blocking or opposing force, angiotensin allowed the virus to cause lethal lung injury. And what does that mean? This pro-inflammatory effect in the lung was, number one, tissue damage, which we are seeing with the SARS-CoV-2 as well, tissue damage. And number two, epithelial edema, so endothelial cell damage and vascular damage, and then inflammation. So inflammatory system and the cytokines are there, and that is how the acute respiratory distress starts, that converts into the septic issues and shock. So angiotensin 2 is necessary. In that study, what they did was they blocked the angiotensin 2 receptors, which patients with diabetes or hypertension may be taking, and the result was that lethal injury to the lung was blocked. So that study actually on SARS-CoV here is also, look at this, they're saying that once we blocked the angiotensin 2 receptors, it attenuated acute severe lung injury. It also attenuated, means reduced, pulmonary edema. Taken together, our data shows that SARS-CoV spike can exaggerate acute lung failure through deregulation of renin-angiotensin system. Moreover, SARS-CoV spike-mediated lung failure can be rescued by inhibition of the ATR, which is through the angiotensin receptor blockers. So from this study's point of view, it is actually interesting that people who are taking angiotensin receptor blockers may actually be in a benefit because their lung may have less inflammation. So that's one. Now, those folks who said that, hey, I'm using ACE inhibitor, how is that useful? So let's look at that as well. ACE inhibitor and ARB both do two interesting things for us. Number one, when you are taking ACE inhibitors and ARB, that causes, I have discussed that in the past, that causes an upregulation of ACE2 enzyme on the tissues, especially in the lungs. ACE2 enzyme is opposite to angiotensin 2. So what that does is it helps. So this is the lack of ACE2 would cause inflammation. So if I can reverse that, when ACE2 is present, it is anti-inflammatory. It reduces inflammation. When ACE2 is present, it causes less apoptosis in the cells. It causes the cells not to die. When ACE2 is present, it is a mild vasodilator. When it is present, it reduces the fibrosis of the tissue, which is very important in case of SARS-CoV-2. When ACE2 is present, it removes angiotensin 2. We did this discussion yesterday that ACE2 enzyme, so let's say this is a cell, here is the ACE2 enzyme on it. Remember, this is the same enzyme that coronavirus uses. ACE2 enzyme can take angiotensin 1 or angiotensin 2 and convert them into angiotensin 1 to 7. So now imagine if it takes angiotensin 2 and converts that into angiotensin 1 to 7, it has reduced the amount of angiotensin 2, which is good for us. So now it is very interesting that ACE2's presence can actually counter angiotensin 2's behavior by creating more angiotensin 1 to 7. So now the interesting question will be, how does ACE2 in hypertensive patients become less or more? So let's look at it. This is my last point for today. Look, a patient of SARS-CoV-2, what happens is their ACE2 are down modulated because the virus is using these receptors, these enzymes as receptors and taking them into the cell. That takes out the benefit of the ACE2 from our body, and that exposes our system, lungs especially, to angiotensin 2 damage. Then, if these patients are on ARB or ACE-I, they result into an upregulated ACE2 density, which is protective then. So this is the study that is here, that they said that we believe that ACE and ARBs, this study believes that the virus brings the ACE2 level down. Then these studies, they said that we actually believe that ACE2 is protective. And not only that, they actually are saying, in fact, ARBs have been suggested as a treatment for COVID-19 and its complications. Increased, and then finally, this is a beautiful thing. They're saying increased soluble ACE2 in the circulation. So they are saying instead, and I have a doctor friend whose name is Dr. Vasaris Alexandros from Greek. He's an excellent thinker. And he was talking about, hey, why can't we do this, that we make soluble ACE2 enzyme and we just inject it into the body, just like angiotensin receptor blockers. So we we inject this. So this is a fake ACE2, and let the virus connect with this ACE2. Let the virus connect with ACE2, and now it would not connect with the actual ACE2 on the cells and will not become internalized. So this is kind of a neutralizing concept here. And in this study, they're talking about the same thing. Increased soluble ACE2 in the circulation could bind SARS-CoV-2, reducing its ability to injure the lungs and other ACE2-bearing organs. Using recombinant ACE2 could be therapeutic approach in COVID-19 to reducing load by binding circulating SARS-CoV-2. So that is the discussion for today. I am going to stop here. So what is the end result of the discussion? The end result is the hypertension doesn't have anything directly to do with the COVID-19 severity. If somebody is hypertensive, that is because they may have other comorbidities as well, and they have a COVID-19, so that may make the severity more. For example, blood glucose or heart failure and so on. And please share this. Then in case of hypertension hypertension, if people are taking ACE inhibitors and ARBs, I forgot to show you this study, which is counter to what I just said. And I want to make sure that we are looking at that as well. Here is another study that says that if you are using ARBs and ACE inhibitors, that would increase ACE2 receptors in the lung tissue, which would allow more virus to attach and internalize. So they have concluded to say, we don't think that you should stay on ACE2 and ARBs, you should move towards calcium. However, my other studies that I presented, they actually are looking at ACE2's presence is anti-inflammatory and it reduces the lung injury. And that is a very important point. So I would go with American College of Cardiology's suggestion that if you are taking ACE-Is and ARBs, do not stop taking them. And the studies that are showing that they are actually beneficial. And I also showed you a study that says they're not beneficial. So this is where we are at. I hope that this is clear. Tomorrow we'll talk about hypercoagulability state. So Kevin says there are 102 people here that are more intelligent. Yes, short time ago. Thank you, Kevin. Aslam, thank you very much. So guys, this is it for today. I'm going to wrap up now. Tomorrow we'll talk about hypercoagulability state. My request to all of you, once again, please share this. And an error that I made in yesterday's lecture that I said, renin, this is such a silly mistake, such a simple mistake, that renin is released when there is more blood pressure. That is not the case. When the blood pressure is low, then the renin is released, which then comes in and causes vasoconstriction to improve the blood pressure. Plus, it causes the water retention to improve the blood volume. So my apologies for that. Yes. All right, guys. So thank you very much. And we'll meet again tomorrow. Please share this. Thank you. And I also wanted to discuss something. Do you think that other than the COVID, we should now start talking about some of the exam preps or medical and nursing students? For example, cardiovascular topics or other topics from respiratory system or nephrology. We can dedicate a couple of days to do topics like heart failure, hypertension, diabetes mellitus, their management, and so on. So if you like that idea, please put that down here and I can start another set of sessions for those. So with this, thank you very much and bye-bye.